Good morning, everybody.
Good morning.
And I'd like to say good morning to and welcome to the viewing audience as well. And, you know, I want to first let everybody know, I want to welcome you to this is our 36th program of this year. Okay, 36. We got 52 weeks in a year. Okay? We still have another 4 to go, and that's pretty amazing to say 40 programs in 1 year of 52 weeks. So, yes, I'm very happy to say that. My name, for those that don't know, my name is Stuart Schlossman. I'm president and founder of MS Views and News. And again, we welcome you all here to another MS Views and News educational program. We provide educational programs for those affected by MS, not just the patients, but it's for the caregivers and it's for the healthcare community. So we do welcome you all to be coming. Before we begin, we want to thank today's sponsors, because to do these kinds of programs, we must have sponsors. And to do this kind of program, we want to thank Genzyme, a Santa Fe company. We want to thank Mallinckrodt, Novartis, and Accorda Therapeutics. And so again, we want to thank them for doing this for us today. So thank you, everybody. Today's guests on our panel, we have Patricia Pagnotta, who's a nurse practitioner. We have Dr. Issa, who's an MS neurologist. Lisa Gonzalez-Getz, who's a disability attorney from South Florida. And we have Justin Konitzer, who's a neuropsychologist. And I'm going to let them each introduce themselves. And they're going to introduce themselves real quick. And by the way, I'm going to be out in the audience with a mic. We want to hear your questions. We're going to go around the room. So we'll start at this table, then go to this table. We have questions from the audience. And for whoever is on our viewing audience right now, if you did not submit a question that we already have, you can send a text message to me at 954-684-1683. We will get your text message, and we'll fill it into this program. Again, if you're on the viewing audience and you want to send a text message with your question, just send to area code 954-684-1683. So let's begin. Patricia Pagnotta, you're first.
Hi, I'm Patricia Pagnotta. I am a nurse practitioner that works in Maitland at the MS Center of Greater Orlando, which is a division of Neurology Associates. I work with Dr. Issa, Dr. Honeycutt, and Dr. Nieves, and there are 4 nurse practitioners in our practice and have been taking care of MS patients for over 10 years now.
Good morning. My name is Dr. Arnaldo Issa. I'm a neurologist in the Maitland area. Work with Tricia with our group Neurology Associates in the MS Center of Greater Orlando. I've been in town almost 17 years, and we have a very large and active MS patient population. Para los de habla hispana, mi nombre es el Dr. Arnaldo Issa. Estoy con el grupo Neurology Associates en el Centro de Esclerosis Múltiple de la área metropolitana de Orlando y hemos participado en el manejo de pacientes con esclerosis múltiple en los últimos 16 años.
Good morning. Thank you for having us. My name is Lisa Gonzalez-Getz. I'm an attorney in South Florida. I practice Social Security disability law, exclusively only Social Security disability nationwide, but we are located in South Florida. I am a graduate of University of Florida and Temple Law School, and I graduated and passed the bar in 1992 and have only been doing disability law. So this is my passion. Mi nombre es Lisa González Getz. He estado aquí en la Florida desde el 84. Estudié en la Universidad de Florida y en la Universidad de Temple Law School. Gracias.
And good morning. I'm Dr. Justin Konitzer. I'm a clinical psychologist, and I have background training in clinical neuropsychology. I currently work for the Orlando VA in primary care, behavioral health, and I also do some private practice work in the community in neuropsychology.
Great. So now we're open for questions. I just want to let persons know that these questions are all coming live. We have not been pre-screened. We have no awareness of what these questions are, so you're getting our total attention.
Okay, so our first question is going to be from a caregiver.
Good morning. My name is Howard Brenner. Just curious, as one of the things that I've struggled with, my wife's had MS for 8 years, that how do you know when something, an ache or a pain, is MS related versus just an ache or pain? Like recently she went to her neurologist or her nurse practitioner because of a shoulder pain. Turns out she may have a rotator cuff injury, but yeah, how do you determine when it's just a pain versus an MS exacerbation?
Well, that's a very, very good question, and sometimes that's hard to determine. So MS is rare, and so I don't want to say that everything should be first MS, and we have to look at things holistically. So sometimes you will have to be evaluated by both your neurology care team and by primary care. So the best thing is to call, let your care providers know what your problem is, and then be open to being evaluated based off of the symptoms that you tell them, whether it's a neurological problem versus an orthopedic or GYN or any other type of problem. But usually it requires an assessment in the office to determine that. So knowing your body and knowing if something is different, and then letting your healthcare providers know, and we'll field that out for you.
Okay, on the other side of the room?
I have MS. I have a lot of difficulty swallowing. I'm in the process of having an endoscopy with dilation. And I was wondering if anyone had this procedure done before. If so, if it was successful, and if there are any other options for me.
Well, it's difficult to know exactly, listening to that limited story, whether or not that's specifically MS related, because people undergo, dilatation of the esophagus for lots of different reasons. So it's unclear, but that is a common procedure that's done by gastroenterologists and for assorted reasons. Generally, it's beneficial for patients.
Hi, I have a couple of questions, and maybe it could be between Dr. Isa and, I can't pronounce his last name, Justin. I'm sorry, Dr. Justin, if you don't mind.
Dr. K works usually.
Dr. K, perfect. I cannot pronounce your last name, I'm sorry. Okay, one of my questions is about, I heard the medications or injections or pills can, the purpose or work weakening our immune system. That is kind of work with MS, or maybe you can clear that for me. Because I noticed that when we have our immune system low, we can get all kind of different infections. So I'm a little confused how that works with our immune system.
So some of the medications you mean specifically for the treatment of multiple sclerosis? Is that what you're referring to? The drugs that are used for the treatment of multiple sclerosis?
Yes.
Yeah. So some of the drugs can affect your immune system and increase your risk for some specific infections, and they can have an impact on your white blood cell count. In general, most patients do pretty well and don't have an exceedingly high risk of, of other forms of infections.
I have a young lady here that has several questions.
Hold the mic closer to your face.
One of them begins with Lemtrada. It was approved, but when will insurance start selling, and what will the cost be?
So the question's about Lemtrada.
Mm-hmm.
Well, I think it was just recently approved, and I don't have any answer. I mean, I believe it just got approved within the last 1 to 2 weeks. So I haven't heard anything from the manufacturer about what the cost is going to be for that, or what the approval process is going to be. It is a drug that's associated with some potential side effects, and the approval is based on, and its use will be for people who have failed 2 other conventional therapies, so it won't be approved as a first-line therapy. It'll be for people who have more difficulties controlling their symptoms with the therapies that are currently available. And the decision-making about cost, I mean, I don't know that that's really understood just yet.
So to add to that question, there is a very detailed REMS program that comes along with Lemtrada. And so that has been outlined. That is a risk modification program that when a drug has, like we all know that Tysabri has a risk modification program. Lemtrada has a risk modification program. So for us to be able to prescribe that drug, we have to be trained about that program. The pharmacies have to be trained about that program. And then the infusion centers, because this is an infusion, has to be trained. So the word from the company is that they're in the process of doing this. They are going to strategize to persons who already have some experience with Lemtrada, and then move on to sites where persons are totally naive. Now, we did trials with Lemtrada. It was alemtuzumab is the name, and so I understand that we might be one of the first to be in Florida, but there are 4 or 5 sites in Florida that were also involved in those trials. And so if that's a drug that you're interested in, please, again, it comes with a REMS program, which means that there are risks that you have to understand and assume those risks, but talk to your healthcare provider about when your healthcare provider would be able to prescribe that.
I just wanted to add also something to tie in with what your question was before. I think as MS therapies evolve, what you're seeing is that some of the newer agents require a little more monitoring. They might introduce some more risk as we modify people's immune systems, and that's just kind of part of the evolution and the process of treating diseases that are associated with the immunological dysfunction. And so the need for a risk modifying or monitoring type program is going to be essential for, I think, Lemtrada and probably some other drugs in the future, because as treatments become more sophisticated and maybe in some ways stronger, I don't know if that's the right word, but a little bit more complicated, you'll definitely have to deal with and have to accept some risks associated with those types of treatments.
Okay, we have a question that came in off the internet this morning, off social media, and it's in Spanish. And so you get to hear my Spanish, and hopefully it comes out good. Lisa, this is for you. It's in English first, and then in Spanish. It's, when do I need to hire an attorney? ¿Cuándo es necesario emplear a un abogado?
Yes. Very good, Stuart. Well, I'll answer it first in English and then in Spanish. You can hire an attorney. You can hire an attorney at any time. Some people hire before they apply, some appeal, and then when they get denied, they apply. Most people are getting denied, and all the paperwork that you write throughout the process gets saved by the Social Security Administration and can be used to either pay or deny your case. So my suggestion is to always get legal counsel or at least advice. Okay. Uno necesita un abogado para solicitar o para apelar una radicación de seguro social. Dependiendo en qué etapa uno está, mi recomendación es que uno siempre tenga consejo legal, gracias, consejo legal, antes de llenar ningún panfleto o información para el Seguro Social, porque esa información se queda en la computadora del Seguro Social y la pueden usar para ayudarlo o para denegarlo. Thank you.
Yes, I've been to several of these meetings, and I always hear people referring to the Epstein-Barr virus. What exactly affect, or what does it have to do with MS?
I'm smiling because I don't know that I have a great answer. That's a complicated answer, so I'll try my best to summarize it. So Epstein-Barr virus is a very common virus. It's a virus in the herpes family. Humans, a lot of us, have been exposed to Epstein-Barr virus. And for many, many years, there's been the theory or the idea that people who get MS get exposed to some type of an infection. That infection stimulates the immune system a certain way. And once the immune system is turned on, it starts to attack the self. It starts to attack itself, the nervous system. And that leads to symptoms that we call multiple sclerosis, but that an exposure to a virus or something in the environment is what flips the person's immune system to be turned on, let's say. And so Epstein-Barr virus has been seen in an overrepresented fashion in infections in patients with multiple sclerosis. And because it's such a common infection that people get, but it's overrepresented in people with MS, there's been this concern that maybe that's one of, if maybe not maybe the only one, but one of the variables that people get exposed to, and that for certain people with a genetic predisposition where their immune system is set up to develop MS or have a tendency to turn on to an autoimmune disorder, Epstein-Barr virus might be a trigger. And so that's one of the more well-studied and viruses that we get infected with. And then the real question, though, of course, is that not everybody who gets exposure to Epstein-Barr virus has MS. And so, why would that be? So MS is not a simple process where, you have one cause and one explanation. There really is no specific cause known right now. But there's lots of theories, and it's like many things in medicine, especially neurology, it's going to be a series of genetic predispositions coupled with some environmental factors that flip your immune system and turn it on in a way that it ends up attacking your body. And that's the case with a lot of other autoimmune diseases that we might have heard of, like rheumatoid arthritis or lupus, which we might be more familiar with or may have heard of, or there are other autoimmune diseases where not everybody gets them, but certainly a large group of people get them, and there's something about that individual's life that stimulates their immune system and makes it turn on and start attacking their body.
Okay, next question. Any new research for MS being hereditary?
I didn't hear the question.
Any new research for MS being hereditary?
Hereditary.
Well, there is a hereditary component to MS, but even in direct twins, identical twins, there's not a one-to-one, not if the one gets, the other's definitely going to. There's only about a 20% increase risk in identical twins. The other twin will come down with MS. So there is some hereditary component, just like Dr. Issa explained with the Epstein-Barr. There are things that we know that put persons a little higher risk, but we have yet to be able to find one thing. So if you have an immediate family member who has MS, then you have a higher risk, but there's not a direct link. So there is some genetic, but not 100%. There needs to be environment, other things that trigger the MS to occur.
Somebody must have liked to hear my Spanish. They actually just texted me a message here. It says, ¿Cómo le digo a mi familia? How do I tell my family that I have MS? Dr. Konitzer, they asked for you.
I'll take that question, and I'll give a response in English. Stuart asked us to keep our answer short because there's a lot of you out there with a lot of questions. I could speak to this answer probably for 10 minutes because it's a difficult one, naturally. I'll try to be concise by saying the consensus in clinical psychology with this disclosure to family of any condition, really, including MS, is that you do it directly as you can, and believe it or not, as non-emotionally as you can, in an effort to recruit support. And I think a lot in the room know that family support is one of the most beneficial factors to have in how you manage and cope with MS. And a lot of people are initially afraid to talk to family members, including children, because they fear that they're going to be a burden, right? And so it's ironic that your fear of disclosing or talking with your family in depth about your condition is actually the very thing that could keep you away from getting the support that you need from family. So again, just in summary, just as direct as you can to bring these topics up to family members in the most non-emotional way possible recruits a healthy communication and conversation that can start you down the path of getting all the support that you need.
So how do we translate that? Anybody want to do that?
I guess I'll go. Para traducir lo que dice el Dr. Konitzer sobre la pregunta es cómo decirse a la familia. Y en resumen, en la manera más directa, más francamente, sería la manera mejor. Es la manera de, vamos a decir, garantizar el apoyo de la familia y de los seres queridos en una manera más directa sería lo mejor, y no tratar de evitar el tema y tratar de no provocar mucha ansiedad en el individuo ni en la familia sobre la nueva diagnosis.
My question is about vitamins. I know there are some we should definitely be taking, and I hear there are some we should not be taking. Can somebody please give us a list of what to take, what not to take?
That would be a very long list. So typically, vitamins, if you are low on certain vitamins, the vitamin that is most associated with multiple sclerosis is vitamin D. We know that there's a lot of research now supporting the fact that persons who have MS tend to have a lower vitamin D level, and that in fact by supplementing vitamin D, you can actually help the immune system. There hasn't been enough research to say that we can say that vitamin D is a disease-modifying medication at this point, but we do believe that it's helpful. So vitamin D is a fat-soluble vitamin. You just cannot willy-nilly supplement that. You need to supplement that and have your vitamin D levels monitored. Outside of that, I recommend patients, if they have low vitamin B12 levels or if they're extremely fatigued, vitamin B12 can help with fatigue. So vitamin B12 typically is not harmful to the neurologic system, and so supplementing pure vitamin B12. You have to be careful with vitamin B complexes because a lot of the vitamin B complexes have multiple vitamin Bs, and vitamin B6 can actually be harmful to neuropathy, and some of the vitamin B complexes now have vitamin C in them. So basically my guidance to patient, although there's not been a large clinical trial to say that a particular vitamin is bad, I tell persons to look at the vitamin and what that vitamin does. If that vitamin is used to improve your immune system, like vitamin C, is notorious for being able to help with your immune system. Persons with multiple sclerosis do not have a bad immune system. It's just confused. It's attacking you. So you really don't want to boost your immune system. You've got a great army. Your army's confused. It's attacking you. You don't need more soldiers, so you don't need to take vitamins that are going to recruit soldiers for an army that's confused. So that's my guidance on vitamins as a whole.
Okay, on this side, person wrote, I get sleepy all the time and it doesn't matter where I am. What should I do?
Right, so sleepiness during the daytime, excessive daytime somnolence is a very common complaint. We see that in the office several times a day, all week, all year long. And so it's not unique to multiple sclerosis. I think going back to the original questions that were raised about how do you know if something's MS or not MS, I often tell my patients, you know, just because you have MS, it doesn't immunize you from all the other maladies that we can all have. So excessive daytime somnolence, you could see fatigue associated with multiple sclerosis. You could also have untreated sleep apnea. It could be a medication-related issue. You could have some other type of sleep disorder. And so the number one cause of daytime sleepiness is still poor quality sleep at night, irrespective of one's primary neurologic diagnosis. And usually a sleep study is the first way to start that evaluation.
And I just want to take an opportunity to supplement too. Behaviorally speaking, I think a lot of times we're looking for the silver bullet, and Dr. Issa can speak to medication and Tricia. But if we're talking about a long-term issue with fatigue and or sleep, don't overlook the basics, modifying your work environment and your work schedule, as well as the general concept of pacing. So setting yourself up with a regular nap schedule, if that's what you find is helpful for you, working activities around that and pacing your daily activities to accommodate the sleep is a good compensatory strategy too.
Hold it close.
Okay, how about in the meantime, we have a question on spasms. They want to know, besides baclofen, what else would work for spasms?
So first, spasms, there's non-pharmacological things that you can do for spasms. So stretching exercises are extremely important, and keeping your muscles nice and loose, and activity. So activity, stretching, those are extremely important. Beyond baclofen, there's interthecal baclofen that can be given that you can potentially use at a lower dose and not have sedation. There is Xanaflex that can be helpful to that. There are other neuropathic pain medicines that sometimes are helpful with spasms. Neurontin and Lyrica sometimes weaker with spasms, but can be used, and other anticonvulsants. So, but first and foremost, again, before adding on medications, it's important that persons are doing the lifestyle things with stretching and exercising to improve spasticity.
Okay, on this side of the room.
Hello. My dad has multiple sclerosis, and there's been several scenarios that he has different pains and everything, and they tend to blame everything on multiple sclerosis. And I wanted to know if it's kind of similar to the first question. So I wanted to know if everything is because of multiple sclerosis, or how can we know that it's not? And also, what are all the treatments, and what are other options that somebody can actually get tested to see if they have multiple sclerosis?
That's a 2-hour question.
Yeah, that's a bit of a complex question, but so let me just take the first step, the first part of that, and again, going back to my earlier comment. So patients with MS, there's no reason MS patients can't have knee pain, they can't have shoulder pain. I would say that my personal experience with my patients is that they generally have just about every pain attributed to MS by other practitioners has been my experience, whether it's abdominal pain or anything else. You suddenly get told, well, that's just your MS, when in fact, that's often not the case. But there's no hard, simple guideline. You simply just need to listen to what type of pain the individual has. So, for example, when I get up from a seated position and I put weight on my leg and my knee hurts a lot, well, that's a knee problem. It's clearly not an MS problem, and that needs an evaluation for a knee condition. If it's more typical MS type pains tend to be burning, stinging, sensations, maybe achy sensations that are distributed throughout the limbs, whether the arms or the legs. So it really comes down to taking just basically, basic doctoring. I mean, listening to a story and listening to what the patient tells you, and then seeing if it makes sense that it could be something related to MS or if it's just some other problem. My experience is that many of the pains that my patients complain about is not related to MS, and it's related to just standard pains that we all get. With regard to treatment for MS pain, we tend to lean very heavily on anticonvulsants, seizure drugs, and antidepressants, which tend to be helpful for pain syndromes related to diseases of the nervous system. And in terms of testing for MS, the standard testing, again, comes down to a history, an examination, seeing if there's anything in the story that sounds like the patient might have MS. MRI testing can be helpful, and of course spinal tap testing, which is done less and less, but still can be very beneficial.
I recently have a friend that was diagnosed with Bellus concentric sclerosis, and what I would like to know is what the difference is between that and MS.
Right, that's a pretty rare condition. That tends to be more of a fulminant, in other words, more aggressive form of a demyelinating disease, and that's sort of the biggest issue. The typical relapse and remitting course is not what's seen with a Bellus concentric sclerosis.
Mi pregunta es para el doctor. Yo sé que hay controversia con el uso de la marihuana, que hay unos que están de acuerdo, otros que no, pero tengo que hacer la pregunta de todas maneras, porque es lo que está sucediendo hoy en día, si es beneficiable para los pacientes de MS.
Can you translate that into English too?
Yeah, so the question is, to summarize the question, is there, the question is on the topic of marijuana and use of in patients with multiple sclerosis. Is it beneficial or not beneficial? Bueno, primero todo, muchas gracias por esa pregunta, porque yo estaba esperando que alguien me preguntara eso. Obviamente en la Florida últimamente tuvimos un debate político. En estos momentos con cuestión de la esclerosis múltiple no existe mucha evidencia que el uso de la marihuana para esclerosis múltiple tiene mucho beneficio. Ahora, hay personas que piensan que eso le puede ayudar con cuestión de espasticidad y para ciertos dolores, pero del punto así médico de que exista muchos estudios o mucha evidencia para el beneficio, francamente no existe mucho. En los pocos estudios que se han publicado, uno de los problemas con la marihuana es que es difícil estudiar la marihuana porque está muy restringida por el gobierno federal. Es difícil hacer estudios para ver si de verdad va a beneficiar a los pacientes. Y eso impide mucho el entendimiento del uso de la marihuana en los casos médicos. Pero en los pocos estudios que existen, no es muy dramático el efecto positivo que tiene la marihuana para esos pacientes en los estudios que he leído yo. To translate, first of all, I wanted to thank him for that question because I was waiting for it to come up. In summary, there's really not a lot of medical evidence for multiple sclerosis, for marijuana use in multiple sclerosis. Part of that is limited by the way marijuana is scheduled in the United States. It makes it very difficult to come up with medical trials. And the limited articles that I've read in the medical literature doesn't seem to have a big impact on things like spasticity or pain. When you measure some of those outcomes, especially with spasticity, although patients have a report of feeling better when they're on the using the marijuana, but it's really just a big gray area. There's not a lot of good evidence that's out there, but part of that is because it's limited to study.
Yes, I would like to ask a question about involuntary tremors. You guys have anything on that? I've been looking, can't find it.
Right, involuntary tremors, right. So tremors with MS can occur. It's usually related to involvement of the cerebellum or the brainstem, and that can be very difficult to treat. There's not any specific therapies available for that. It's a lot of trial and error. Drugs in the Valium family can be sometimes beneficial for patients. Drugs for some of the Parkinson's disease medications can be beneficial for some patients. Some of the seizure drugs can be beneficial, but it's a lot of trial and error, and it's often very frustrating for both patient and doctor alike.
The next question is for Lisa. Person wants to know what it will cost to hire an attorney to represent them when it comes to a disability claim.
Okay. Attorneys that practice Social Security disability are statutorily regulated, which means every attorney gets paid the same amount regardless of experience. Now there are also non-attorneys that represent and also get paid, but basically it's 25% of your retroactive benefits up to $6,000. So the cases are capped at $6,000, and it's based on what they get for you. So basically, if they don't win your case, you don't have to pay them. Few attorneys, I understand, are starting to charge some monies for medical records and costs associated with it. And that's separate from the statute, so you have to shop around with that. But basically, if you don't win your case, you don't have to pay an attorney.
So a question going further from that, though, is that this person was from Puerto Rico. They want to know if the same laws that are here on the mainland of the United States, does that apply in Puerto Rico as well?
Absolutely. It's a federal program, and it applies to all 50 states and Puerto Rico and territories of the United States. So it also applies to Guam.
Very good.
Oh, I'm sorry. It also applies to any person who has worked and put money into the system, is a United States citizen, and is in any other country. So these hearings are heard in embassies throughout the world.
Great.
Interesting.
Yeah, Stuart asked me to ask a question because of my accent, because he particularly likes it. So there have been numerous DMDs, disease-modifying drugs, developed over recent years. Do you see that same pace being maintained, or do you see progress taking place in other areas of MS research outside of disease-modifying drugs?
I see that pace is increasing. So if you look at through the last 20 years, the proliferation of drugs initially with beta-seron coming on to market, then it was a few years before we got Avonex and Copaxone and continued. And now drugs are coming out 2 in a year. And next year, potentially, there will be a few more drugs that go to the FDA. So the issue is the process of going through the FDA, finishing up trials and the process of going to the FDA. The other thing is right now there's a lot of groundwork research being done looking at neuronal repair. So some of those trials are in stage 1, stage 2 trials. There is one that is going to probably come out to a stage 3 trial coming up next year. But there's a lot of work that is going on at a level that has not reached patients yet. And there's a lot of work, again, that has reached a very small population looking at stem cells. So I believe over the next decade, things are going to come out faster than they did before. The only limitation will be the FDA approval process, which pharma companies have no control over.
Yeah, I would just add on to that the one area that multiple sclerosis research has excelled in is in the management, the treatments for early relapsing remitting MS. We still have a lot to understand about patients who start to evolve into a secondary progressive form of MS, which is the more of the degenerative stage. They have less relapses, less of an inflammatory component to their disease as far as we understand it. And that's an area where I think just now you're starting to see a couple of trials coming out, but that's a huge area of need. And hopefully more research will be done in that category, because that's really where a lot of people have more significant disabilities, significant impairments in their day-to-day function, and frankly, we're pretty limited in what we can offer those patients.
This question is for Dr. Konitzer. Person just asked me how a neuropsychologist would benefit a person with MS rather than just seeing a psychologist.
Okay, well, just for those of you out there who don't know what neuropsychology is, neuropsychology focuses on the relationship between your brain and your behavior in the most general way. And neuropsychology involves assessment of your cognitive functions, so your thinking skills, all the way to include motor behavior at times, fine motor skills. And so someone, and I'll let Lisa follow up, but someone interested in getting a baseline assessment of their thinking skills would go through a neuropsychological evaluation. The evaluation involves mostly paper and pencil and interactive testing. Okay, so you're tested on your memory, your attention, your concentration, and your executive skills, or the complex skills, your thinking skills that allow you to execute behavior. And so getting a baseline assessment can be useful for someone who is starting to experience some cognitive difficulties, if in fact you're going to have those, and then getting follow-up assessments as you go along in the course of your disease to correlate with exacerbations or times when you feel like you're doing well, to kind of get a sense of those skills. One of the benefits to doing the evaluation can be involved in your receiving benefits. So a lot of times neuropsychologists will be asked to perform an evaluation for a benefits case. And maybe Lisa can follow up and speak to that.
Right. So before this, we were talking about whether it's important to do these evaluations before you apply for disability or before you're actually diagnosed with MS, because as the doctor said, there's so many different complaints and allegations that you have before you get your diagnosis. So absolutely, your concentration, persistence, and pace, your ability to follow through and understand limited, simple instructions, these things fall into the category that help not only diagnose MS, but also develop a proper file and a record to get disability benefits. So many of the times people have, like the doctor said, history of complaints, examinations, MRIs, and they're inconclusive. And so by the time I get a case and the person's presenting their case before an administrative law judge, we tend to say the MS has been spawning, has been, coming from the last year and a half, and we can show these are complaints. And a lot of the judges say, well, the diagnosis didn't come into play until a year and a half later. So they want to cut 18 or 20 months of benefits that a person is rightly entitled to. So these cognitive tests are important to do at the onset of complaints. It doesn't mean that if you're depressed, it doesn't mean that if you're having muscle weakness, you automatically have MS, but it does help in giving an overall picture of a baseline and take it from there as to how you're able to manipulate and function physically as well as mentally combined. Thank you.
I just wanted to add one other thing to that from a clinician standpoint. In our practice, we certainly lean a lot on our neuropsychological colleagues. And one of the benefits from my standpoint is that having someone with a psychological background that has a better understanding about how brain function impacts your behavior, your decision making, and even your interpersonal relationships, I find very helpful. I think that a lot of times with the traditional psychology that counseling is a lot about relationship management, and some of the models and some of the paradigms, maybe, that I'm not sure that's the right word that they use, I don't think it always applies well to people that might have some cognitive impairment from a neurological disorder. And so the way you communicate with your spouse or other significant other, and helping that individual understand why are they saying the things that they say, why do they act the way they act. And sometimes when you frame it in a kind of a conventional relationship model from a standard psychological standpoint, I find it not really very satisfying. So I like having the neuropsychologist be able to help us out with that.
That was a multi-part question. Does Tricia have something to put towards that?
No, I agree with that. The neuropsychologist, defines the problem, but the most helpful thing beyond defining the problem, as Dr. Issa pointed out, is that follow-up and the vocational and family counseling. The recommendations from that are instrumental in helping not only the person who is affected, but the family members that are affected as well.
Okay, in the back of the room.
Okay, this would probably be going to Lisa. I know you deal a lot with Social Security law, but this is a little off topic, and I wanted to ask you, can children be taken away in a custody battle due to being disabled, having MS, and being hospital bound, wheelchair bound, and considered bed bound and wheelchair bound? Could they be taken away for that reason?
Okay, that is a very important question. That is unfortunately outside of my realm. I will address it to say that this is a fantastic country where ADA rights are administered and supported and protected every day. So probably the best way to handle that would be through your therapists and your doctors, as well as the state and the county where you live in. Every county differs and every state differs, and so I would ask you that would be the best and the most viable alternative to get your proper answer based on your specific complaints. However, in this country, ADA is ruling since 1980, and that's pretty much protecting your rights.
Okay. Thank you.
You're welcome.
I always pronounce this wrong, but a pseudo-exacerbation, and well, you can say it real quick.
Pseudo-exacerbation.
Okay, saying that, okay, can you explain what that is? And let's say I go to work and I have that, okay? And then I want the Social Security lady to say, does Social Security recognize that as far as a side effect and being able to work or not?
So pseudo-exacerbations, flare-ups that are not related to new activity that's going on. And how we define that is that a relapse that is related to potentially new activity is something that lasts longer than 24 hours, something that cannot be associated to anything other than something coming from your central nervous system. So the other term for pseudo-exacerbation sometimes is a thing called UTOS phenomena. And so that's something where your body, because of lesions you already have, develops a symptom. And it could be a symptom that you repetitively have. An example of that would be a person who had an optic neuritis. When they get overheated, that would be the trigger. They may have blurring of their vision, and such blurring that they can't even see for a period of time. But usually, again, bringing the body temperature back down to normal resolves the symptom. And so that's from an old lesion that occurred in the past, not something new. So that's the key, and that does impair persons. So when you're having false exacerbations, meaning your symptoms are not well controlled because of environment or infections, sometimes persons with urinary tract infections, persons who are overly exhausted. So managing your environment and managing the underlying cause is how you would stop having pseudo-exacerbations. And so looking for that is the key. That does impair a person's abilities. So I would like to hear what Lisa has to say about that.
Actually, it's very interesting because when we have patients or clients that get put on treatment and have consistent medical care, as we hope for everybody, you see an improvement in your symptoms. And then when you feel that, well, I'm okay, I'm going to go back to work, and you do return to work, you may have these kind of symptoms that came out of the blue. Pseudo-exacerbation is one of them. For Social Security purposes, once you start working, they're going to flag your case to see how much are you able to work and whether or not you are artificially keeping your levels and of amount down or your hours down artificially so that you can double dip, receive benefits as well as work. So I would advise that prior to going to work, if you start seeing any of these symptoms, because you have to get ready, you have to prepare, now you have a schedule, you have to get to work by a certain time, many times you have to drive there, then you have the stressors of work, then you have to go back home and kind of have your schedule of going back to work again. These things can create other imbalances in your life, which create imbalances in your treatment. And the way you combat against it, if Social Security reviews your case and determines that you are no longer disabled, is through your medical records. So it's very important that if you do want to work or if you do have any complaints, you get it recorded with your treating physician. You complain, you document it many times, and I see some of the pharmacists, pharmaceutical reps have journals. Journaling is a huge way of keeping track of your day-to-day or your week-to-week or your month-to-month, because that could be brought in as evidence if you were to end up before a Social Security judge and indicate that these are things that are persistent and are affecting your ability to work. I hope that answered your question.
This question is for Dr. Issa. There was a gentleman who stopped by our support group, and he had gone through numerous testing with his neurologist, and he believed he had MS. It wasn't MS, it wasn't lupus, it wasn't Lyme disease. So they finally told him it was ataxia. I never heard of that. Can you shed a little light on that? Is that also something neurologically or autoimmune?
Right. Well, I don't know the specifics of the case, but there are a series of neurodegenerative ataxias, often referred to as like spinal cerebellar ataxias, which are genetic disorders which predispose people to degenerative diseases, usually with balance. Could be with swallow, it could be with, almost always affects mobility, could affect speech and cognition. Those are very rare conditions. I would say that maybe in 16 years I may have seen one patient in private practice with an ataxia. It's not, so my own, you might see that more at a university center where you get referrals for obscure neurologic diseases. But there is a series of degenerative ataxia syndromes that are out there.
The next question is for Tricia Pagnotta. Person wants to know, what is the walking pill?
So what is the walking pill? That's a drug called Ampera. And Ampera is a drug that is a calcium channel blocking agent that has been proven to help persons increase their walking speed. their quality. It's tested through walking speed, but it improves the quality of walking because not only in the studies looking at the ability to walk faster, there was the MSW12, which looks at the whole quality of walk. So how it got approval through the FDA is walking speed. We have to test that, but it's a drug that's given twice a day to improve walking. So if you're having a walking difficulty, you can talk to your healthcare provider about that drug.
Lisa, I hear that what you're saying about not earning money while you're on Social Security, but what is the maximum amount you can earn per month?
Okay, every year it changes. So for the year of 2014, it's $1,071 a month. But again, I want to caution you, anytime that you start working, you are raising a flag to your Social Security number. And once they see income, they're going to determine whether or not that income is all you can do or all you believe you can do. And then that becomes an interpretation that has a lot of trapdoors. So I would caution you to keep the amounts as to sustainable work. So if you're going to work and you're going to bring in some income, the question is sustainability. If you're only able to work 5 or 10 hours a week, keep it at that level. Don't start trying to over-endeavor yourself and then find that you're going to be reviewed as well as medically not feeling better.
Okay, again, for Tricia, we have, what can we do about that feeling of feeling like this sunburn on the legs? What has to be done to get more comfortable? Because evidently this person is having problems with like a Lyric or I forgot the name of the other drugs, but you know, to take away some of that tingling pain or that burning pain that they're getting, what else can they possibly do?
So tingling and burning pains are typically categorized as neuropathic pains, and yes, the anticonvulsant class, Lyrica, Neurontin being the first, were most successful for some people. But for other persons, the antidepressant class is very helpful. So older antidepressants that are no longer used for depression because of potentially side effects and they don't work as quickly as some of the newer antidepressants are often very helpful. Then compounding pharmacies also have creams and whatnots that in locations like an extremity where the pain is more isolated, potentially some of these creams can be helpful. So there is a myriad of drugs that can be tried to help with this pain and have been successful for persons.
If you have a suprapubic catheter and you are every week to 2 weeks on antibiotics, let's say oral isn't working anymore and they put in a Mediport and now you're getting IV antibiotics and it continues to return, what should one do?
Well, that sounds like a definite case for, I hope you have a urologist that's working with that. Unfortunately, sometimes urinary tract infections, you can get an organism that gets colonized, and it is never eradicated. And depending upon, again, the organism, it might not be something that you need to have treated. So my advice would be that person should see a urologist, and that urologist potentially working with an infectious disease doctor if this is not a colonized organism that it keeps returning. It just is then maybe the matter of the right antibiotic. But you know, going back to the basics beyond the antibiotic, when you get on an antibiotic and you cure an infection, and if it reoccurs, then you know, going back to basic training, getting home health care persons to come in to make sure that you're cleaning your catheter properly, you're changing it properly. So going back to the basics is first getting rid of the infection. If it reoccurs, is it something that's colonized and is not going to be able to be cured, and so therefore treating it is just a waste of time. Or if it's not, then consulting with a urologist and an infectious disease doctor may be appropriate.
Okay, but if it's colonized, can that affect you? Would that like affect you in some way where it's, you know, because when you have the infection, you're with spasms and you have pain, will that ever be cured? Because there is a urologist involved, and my next step was the infectious disease doctor. How do I, you know, what would I do to find out if it's colonized, and is it something that you would have to like just, you know, deal with and live with?
You know, again, I think that if you have a urologist and an infectious disease doctor, they should be able to determine for you whether that's colonized. And if it is, regardless of what it's colonized or not, again, treating your symptoms, you know, sometimes acute infections do, again, cause these, quote, pseudo-exacerbations or a flare-up of your symptoms. So you will need someone, you know, to work with your urologist, your neurology team, to treat your symptoms while your infection is being managed.
Hello. I've heard of many MS patients benefiting from deep brain stimulations. In which way would this be beneficial?
I'll be honest with you. I don't have any experience with anybody with a deep brain stimulator for MS. I'm not aware of that being a widespread use for MS patients. So I'd be curious to know what the deep brain stimulator was used for and where was it implanted. But I would say in our practice, I don't think we. Yeah, we have nobody in our practice that has a deep brain stimulator. I've never read about that, and I'm not sure what that's been used for.
Not for MS. I mean, deep brain stimulators, but not for MS.
Yeah, certainly for Parkinson's and dystonias and other movement disorders. So I'd be curious to know what that was used for and where was it implanted in what area of the brain.
There is a center in Atlanta that is doing that for people with MS and other neurologic conditions, so we could always find out from there too.
Yeah. Okay, our next question. Are the services of a neuropsychologist covered by most insurance companies?
The simple answer is yes. Yeah.
I have a question for Lisa.
Yes.
So disability has an obvious perception issue, whether it's cognitive or physical. So we have a friend who's very active, but he's cognitive. He's on disability for cognitive issues. So how do you? Is there one more than another that's accepted by the Social Security for a disability, and how do you deal with that perception as people start to see you? For example, he's a runner. I talked about him a little earlier today. He's running a marathon this weekend, but he's disabled or he's not working because of disability.
Wow. Okay, so the definition of Social Security disability is a person who's unable to work because of a medical impairment, physical or mental, for a period of 12 months or more, or resulting in death. Okay, that definition is very broad, and it deals with both cognitive, physical, mental, emotional, somatic. It deals with all kinds of medical issues. And therefore, if a person is able to do any kind of work, rip a ticket in a movie theater, stare at the TV, and if there's a problem, dial 911, any kind of work for a substantial gainful basis, which is defined as 40 hours a week consistently, the person can work.
If you suffer.
I'm sorry, I was just going to follow up real quick. I think Lisa mentioned the broad definition, the disability definition. I think we all know in the room, at least, that MS is a broad condition, spanning cognitive, physical, and emotional domains. So, you know, to get at your answer there, that you can have deficits or weaknesses in any one of those domains, or multiple domains, or none at all at times. You know, so a runner or someone physically capable who has cognitive deficits certainly, I think, would fall under the definition of disability, and vice versa.
It depends, though, because you can also have somebody say, well, there are plenty of people. I mean, we live in a country where ADA rules. So we are trying to protect the disabled. And there's that other side of the coin also, which means if a person is disabled and they want to work, they should be able to work, and we should make accommodations for them. So if a person cognitively is at a lower IQ or unable to recall and remember simple job instructions, the question then becomes, if they're physically fit, if I were a judge trying to determine disability, well, would they be able to do work as a mover and move furniture around, or are they able to, and would that translate into money? And if they can do that, then they're not disabled pursuant to Social Security guidelines. So, you know, my passion is this, but what I see on a daily basis is the other side of that argument.
So can I, Lisa, in a question that commonly I get asked is, if a person physically was, like, let's say a person was one of your professions, a lawyer, and because of their multiple sclerosis can no longer function as a lawyer, could they get disability because they could not support their family? And that may mean not necessarily government disability, but disability going through their insurance that they've paid for disability. So you speak to that.
Yes. So what I do is Social Security disability as it pertains to the federal law and the federal Social Security Administration agency. Then there's also private disability groups, which are contractually based. So every person who is applying or fills out an application at work for short-term or long-term disability, and those are their own definitions of it. So I would suggest to get advice on your particular disability policy and insured, and there are attorneys that can help with that, and I can certainly help with that also. Now the question becomes whether or not, if I were to become disabled today and I were unable to practice law, would I still be entitled to disability benefits? That requires an evaluation based on your age, education, work experience, and vocationally relevant factors. With that said, it becomes a question of maybe I can't go to court anymore or represent individuals, but perhaps I can teach, or I can speak, or I can do other things with the skills that I have acquired. If that's the case, then I am not disabled. I had a client that was a medical doctor, and he was a surgeon. He was a neurosurgeon, and he developed Parkinson's, and he was unable to do surgery anymore. The Social Security Administration was trying to deny his benefits because they were saying maybe you can't do surgery anymore, but you certainly have developed the skills and the knowledge to transfer that into another industry and make money. In this particular case, we were able to go into the cognitive deficits, the weakness, the fatigue, the tiredness, how that affected his self-esteem, the mental problems that it created with his family. We were able to get disability benefits for him on that basis. He was also of a certain age, so he fell under a certain category where the skills were not transferable to another industry. So there's a lot to look at in evaluating those claims, and normally the more education and experience you have, the easier it is for the Social Security Administration to turn around and put you in a vocationally relevant work which would gainfully employ you.
I just want to add one last thing that would be helpful to physicians and nurse practitioners. I think if you're pursuing or thinking about pursuing disability, that you think that's an important avenue you need to explore, I would strongly encourage you to discuss that with your clinician when you're thinking about it. There's nothing more frustrating, I will tell you from my standpoint, than never ever having a discussion about disability and then getting 27 pages from the Social Security Administration for me to fill out about something that I've never discussed with the patient, and then expect to fill that out in 2 weeks for some upcoming hearing that I've never heard about. And I have no idea what the person does for a living. They've never shared with me once why they don't think they can work. They've never shared with me how their disease affects their work. And then I suddenly have to somehow come up with some answer. So it puts the clinician really in an absolutely impossible position, and it would just be so much easier. Also, just to back things up, you talked about the medical records. In general, in my medical records, I would say, by my nature, I never really reflect anything about impairment as a routine matter. Of course, I don't ask those questions routinely. I sort of focus on their medical complaints. But if it's important to you, you should share that with the clinician so that they can start documenting in the records what your work was like, what your symptoms are like, and that fleshes it out. Because if you read most of my notes, there will be absolutely no mention about how your disease affects your vocation. And then sort of finding out at the very end, after you've been working with someone for 4 years, that they're in the middle of a disability claim, it's impossible. When you look at medical records, they absolutely will not support your case. And you know, and mentioning that to me is not going to work with a few weeks time.
I'm going to run this tangent just for a few more seconds to say Dr. Issa mentioned earlier he leans on his neuropsychology colleagues to assist him. And I was brief on the answer to the neuropsychology question earlier, and I should follow up by saying neuropsychology is the merging of neurology to some degree and psychology. And so not only does neuropsychology assess cognitive functioning to include fine motor skills, but also emotional and psychological functioning. Okay? And in the course of that evaluation, a pretty comprehensive vocational and academic history is taken. And also, as Tricia mentioned, it's taken in consideration after the evaluation is complete. So, for example, to pull all the pieces together here, if you have some cognitive weaknesses or limitations secondary to your MS, a neuropsychologist can help put that in the larger context of who you are as a person to include what you do for a living and where you came from academically and vocationally. So hopefully that helps answer why it's important.
By the way, no question is not worth asking, whether it be a one-word answer or a four-person answer. We want to hear your questions, so please keep bringing them in. They're all great questions.
Okay, the next question is about the difference between a neuro-ophthalmologist and a regular ophthalmologist.
Well, the biggest difference really has to do with training. You have to do a neuro-ophthalmology fellowship after you're done with your ophthalmology residency. And just like the neuropsychologists, I think they're just more in tune with disorders of the nervous system that affect the way your eyes move, the way your optic nerve functions. And so we work in particular with a neuro-ophthalmologist that's familiar with our MS population. He knows what questions we're asking, what we're looking for, and we find that very beneficial.
Okay, question that just came in again, text. Could Copaxone be cause of my tendons to calcify? I've been on this drug for 10 years. I'm in constant joint pain. I was told about the calcium issue from MRI.
I have not heard of that specifically associated with Copaxone, and if so, I'd have to look something like that up. I've never heard of that specific side effect of. Have you?
No, I haven't heard of that of Copaxone. And the best way, if you are having a side effect on a drug, you talk to your healthcare provider and you report it to the company. If you report it to the company, it has to be followed up. And so that's how we get side effects. So if that person believes that might be associated to Copaxone, report it through shared solutions. They will investigate the data bank of all persons on Copaxone and determine whether or not that could be related to Copaxone or other medical conditions.
My question is about Botox. I have heard about Botox for spasticity and Botox for bladder issues. I assume it's Botox injections into separate places, and Botox doesn't know where to go to make one feel better. And could you talk about the possible side effects and if it's a good idea to use Botox at all?
Right, well, let me take that question since I inject a lot of Botox. So Botox for spasticity can be helpful to patients with specific areas of spasticity. So if you're looking in particular to make some improvement in the tension and the posture and the position of, for example, hand muscles, forearm muscles, or leg muscles, it can be helpful. If it's very large muscles, like in your thigh, Botox tends to be less beneficial for those patients. And with regards to your bladder, that's done by certain urologists. And you have to find a urologist with some experience with Botox in the bladder. But if the patient's symptoms are real specific, Botox can be pretty beneficial for a spasticity. Side effects are going to be rarely flu-like symptoms, and rarely you can get some what's called a spread effect, which is where you can develop weakness in muscles outside of the ones that were injected, and sometimes you can get excessive weakness in the muscles that are injected, but that's kind of an expected side effect, since the point of Botox is to weaken certain muscle groups.
Lisa, when a person receives SSDI, how is it determined if they will be on Medicare or Medicaid? And why does it take so long to get Medicare insurance?
I'm going to start with the end first. Medicare insurance is 29 months after you've been found to be disabled. That's when it kicks in. There's a 5-month waiting period, and then 24 months after that. The length of time that it takes to process these cases, particularly in the South right now, has extended and extended and extended. And there was a meeting just yesterday with the regional chief judge for this whole area, and it doesn't look like the delays are going to speed up anytime soon. So they're looking to hire more administrative law judges, and it looks like we're going to have another year and a half of this delays. With respect to what kind of benefits you're entitled to, it's determined at the lower level, at the district office level, based on the work that you've done. How much work you've paid into how much work you've done, how much money you've paid into the system, and they will decide whether or not you're entitled to Title 16 of disability or Title II of disability. Title 16 is a welfare-based case, and it's normally for people that have not worked or earned enough money into the system, and that one will give you the health insurance of Medicaid, which covers 100% of your insurance needs, including medicines. If you have worked and paid money into the system, meaning Social Security, taxes, then you would be entitled to Medicare if you're insured, and that's under Title II. And Medicare will cover 80% of your needs. I understand it excludes medication, and Medicare doesn't kick in until 29 months after the date that you've been found disabled.
So we continue being poor, paying private insurance if we have private COBRA.
Yes.
Okay, thank you.
You're welcome.
The question that's being asked is, what other modalities can you use besides medication for depression?
Well, I'll take this. The short answer is psychotherapy. And I'm curious, I'll interpret this for our home audience, but how many in the room here have been involved in therapy, if you're comfortable sharing, and found it beneficial? And by therapy, I broadly mean counseling therapy. Again, you don't have to share, but okay. So, so psychotherapy or counseling, sometimes the terms are used interchangeable, is very beneficial for depression or any mood issues in general, and as relates to MS too. I don't know if I can expound on it more. It would be a dissertation to get into what psychotherapy can do and is. It's very individual based, believe it or not. There's not a broad silver bullet answer for psychotherapy and MS, other than to say psychotherapy is a very good means to help you build coping skills, individual coping skills to help you cope, and also help in the larger family context, where obviously role shifts can happen pretty significantly when someone comes down with a disease like MS.
Just so everybody knows, we're just a little bit beyond the halfway mark, so we still have a lot of time to ask questions, okay? We will get around and get everybody's questions.
This is a question for Lisa, and maybe you won't be able to answer, but maybe the others panelists can answer. I know you do just Social Security, but one concern is power of attorneys or health surrogate. It's a document that I consider very, very important in these days because of the situation, for example, of a health condition. And it's a nightmare for caregivers, sometimes to take good care of their loved ones or friend ones. So do you know anything about it? And maybe the doctors have experience sharing information that they can't give to somebody because they don't have a document?
Well, I'll touch on it very, very quickly because I don't know much about it. I know that it's important to know that whoever you designate, you have it documented. Now these forms are online, but that you also have that the people or the person that's entitled to get information available to you. So many times we give these forms to somebody who's close to us at one period of time and then they move or they're not around when you do need the help. So I'll pass that on to the doctors.
Before they answer that, I just want to let everybody know at our symposium that we did on October 25th, we had an attorney speak about the caregiver rights and financial responsibilities. That question was answered. So if you go to the YouTube channel and look up that portion of the program, you will see the answer to that question, or you can hear it too. Anybody up there?
So the durable medical power of attorney is a very simple document that anytime you enter into a healthcare facility as an inpatient, they ask you if you've ever established this, and they actually will provide it for you, and you designate an individual, and it's witnessed, and so that person becomes. So that's very simple to do. The discussion is really, have you discussed with someone what you would want done in the event that you're not able to make decisions for yourself? So, you know, that's the first thing, is having a discussion with your family members about what you would want to have done, what your wishes are about your healthcare needs, and then designating a person puts that into place. The other thing that you touched on was persons who can get information about you. So different from a durable medical power of attorney, which designates a person to make decisions when you can't make decisions. The other thing is involving the HIPAA law, meaning that when your spouse calls our office and says, my wife da-da-da-da-da, and she was just in and da-da-da-da-da, if you haven't, when you came into our office, designated that your spouse can get information about you, despite the fact that he loves you, is with you all the time, he can't call into our office and get information about you because that would be breaching your HIPAA, that would be violating your health information that would then put us at risk of going to jail. And as I tell persons, I don't look good in orange. So if you want people to have information about you, you start putting that in place in everywhere you go, every time you interact with healthcare providers. So maybe when you established care, you weren't married. And when you get married, when you go back into the office, you ask them for their HIPAA form so that you can put your loved one on, or maybe some dynamics in your family changed and you want to add someone else on. So those are the type of things that, you know, again, you need to initiate those, and every healthcare interaction you have, the persons in that setting, be it office staff members or in hospitals or surgery centers, they all know about that. So if you ask them, they can help you with the proper forms.
And to offer a little empathy here, I'm often on the receiving end of frustrated loved ones, spouses, you know, saying, well, you know, my loved one wanted me to make the next appointment. And HIPAA, in the strictest sense, a provider's not even allowed to tell you that they see a patient or that they have a patient. So if you're a loved one and you have a relationship with the provider and you know and he or she knows, still in the most strictest sense, we can't even share that information that your loved one's a patient, and certainly not schedule without speaking directly to that person. So I encourage you to please get those release of informations filled out if you're going to have a loved one be communicating with your provider directly for scheduling purposes and whatnot.
Next question is about overactive bladder and what they can do to overcome that overactive bladder.
You got to hold that mic closer so that everybody can hear you, please. Say it again.
So overactive bladder is a common problem. And so, again, urology is very helpful in making a determination as to whether this is a bladder emptying problem or a problem with which sphincter is a problem. And so urodynamics is extremely important, and then following up with the appropriate medications. But I go back to asking persons to assess their diet and their intake of fluids, knowing that there are certain things in your diet that will stimulate your bladder. And so is your bladder truly overactive, or are you stimulating your bladder in another way? I ask persons to, it's very important that we drink plenty of fluids, but if you are drinking fluids all day long versus drinking at designated times, I use the analogy, if you sip, you're going to drip. So if you drink quantities of water and then have periods of time where you're not drinking, then you'll be able to empty your bladder, have your bladder empty, and go for a period of time where you don't have to empty your bladder. But if you're constantly filling your bladder, your bladder's constantly needing to be emptied. So beyond those type of things, a good urology consultation to figure that out is appropriate.
Okay, again from the internet, just came in. Could you please address memory and cognitive issues? I'm a teacher and find it very difficult to process certain concepts that I previously knew. I have memory issues that are becoming disabling and embarrassing. How do you recommend to help?
I'll start and then maybe I can pass it down. Memory is the #1 cognitive complaint for individuals with multiple sclerosis. And speaking to the neurodegeneration, the demyelination that happens, there's issues with processing speed. It's often not talked about. Processing speed is the speed at which information travels through your neurological system, and we usually talk about information processing speed. What we see in the neuropsychology literature often is that sometimes memory issues or subjective memory complaints, your experience of memory issues, are more secondary to processing speed issues, okay, slower information processing speed, than they are related to any bona fide issue with the centers of your brain that deal directly with memory storage. And so, as an example, I've done this before where I can say, do this math problem for me, if you would. 2 + 8 × 5 - 3 + 18 divided by 4. You can give me an answer, right? Now, if I were to slow it down and give you enough time, or if you were to write down the problem, most people can probably come up with an answer. But I gave you the information far too quickly for you to process with any quality to be able to give an answer. So you don't necessarily have an issue with your memory. I forgot the problem. I forgot what you said. It's just that you weren't able to process it as quickly as maybe you used to or you could. And so that's one part of my answer, is that a lot of times if you give people cues or if you allow them enough time to process information, they can often generate recall fairly well. In other situations where neurons do deteriorate or scar tissue is involved, they can't produce a memory. And so they do have bona fide memory issues. And I think the question said, okay, so if I have these memory issues, what can help? What can I do? Especially, I think this person was a professional. And there's a two-part answer here. Number one, you can develop strengthening techniques working in cognitive rehabilitation programs where you're exercising your brain and the neurons that you do have left that are thriving and functioning well. And then the second part is where systems in your brain are impacted and perhaps for a long time, you can develop some compensatory strategies where you're not necessarily trying to strengthen the pathways, but you're trying to do a workaround. And some of the basic ones for memory issues are things like note-taking, reminders. There's a lot of electronic applications now with smartphones that you can use to help remind you of certain things, and the like. So maybe I can pass it on because I think Tricia and Dr. Issa might have some ideas too.
Well, I would just say that when it comes to cognitive issues with MS, it's important to recognize that that's very common. And also, from my standpoint, one of the first things I think about is non-MS causes of cognitive issues. So that's important to explore: thyroid disorders, B12 deficiency, polypharmacy, depression, sleep disorders, untreated sleep apnea. Those are all very common conditions in the general population, and there's no reason people with MS can't have any of those problems. And it's also the medications. I mentioned polypharmacy, to me, is a big issue. It's easy to accumulate lots of different medications when you have a condition like MS, and they can all, either as singularly or in combination, affect one's cognition.
So, just to add on to Dr. Issa's, I agree with him 100%. So when you find the cause, then you start treating that. And so, it's treatable.
On the future of clinical research studies, I know that one of the topics that was on the brochure was myelin repair. And I know that that is a discussion of something that's coming and going. And is there any going on right now for that specifically, myelin repair?
There's a lot of research going on myelin repair. So it just depends at what stage you're looking at. I think the next one to come out to be available in larger clinical trials is going to be the anti-lingo drug that we hope to get in research trials at the beginning of next year. But there are several drugs that are in the stage 2 trials, and several drug companies have them. And in talking with pharma companies, there are things that they're doing in their labs now that don't even have names, that they're just looking at mice to see if they're working with them. And so there's a lot going on in that arena. But the only one I know that's going to come to a larger clinical trial likely next year is the anti-lingo one.
I have a friend that has MS, and it affects her respiratory system, so she has a lot of problems breathing, and she goes into these coughing spells. But something that was recommended to her was chemotherapy. And so I wanted to know if that's still an option, if that's something that they're promoting now.
Well, without knowing a lot of the specifics, I mean, sometimes if people have very aggressive forms of MS, you can do some aggressive types of chemotherapies like a Cytoxan, which is a medicine that largely sort of just eliminates, lowers your white count substantially. And sometimes doing that in several months course can help sort of reset, or at least put the immune system in remission if the patient just has a relentless cause of their MS. The other thing is some of the like a drug like Lemtrada, which is a chemotherapy. It was used in blood cancers. Could also be an option in patients like that. It has an indication for
B-cell lymphomas.
Yeah, B-cell lymphomas. Thanks.
Next question has to do with vitamin D. I know we talked about the different supplements that you should and should not take with MS, but we're asking how much vitamin D you should have a day, how much you should supplement.
That's dependent upon your vitamin D level. So we want to keep persons' vitamin D levels between 60 and 100. So most of the clinical research is looking at maintaining a level between 60 and 100. And so if your level is 18, well, then you're going to need a lot more than a person who is 50. So again, vitamin D is a fat-soluble vitamin and should be supplemented with someone monitoring what your vitamin D levels are.
Question from Oregon. Person seems to have a lot of symptoms that she had going back to the mid-90s. And all of a sudden, a lot of these symptoms are starting to come out again. And then there's other things that she has where she's developing what she feels may be new symptoms. But she really doesn't know for sure what, and if these are really new to her MS, old to her MS. She wants to know when is it correct for her to be contacting her neurologist when these types of symptoms occur, or should she be seeing somebody else?
I mean, that's a difficult question to answer. It's a little vague, I think, in terms of all that. But I think a general rule is if you have symptoms that last more than 24 hours and they're persisting in other words, not just my hands go numb when I grab a steering wheel for 30 seconds and then I feel normal. I mean, that's not going to be MS. But if it's a persisting symptom that's new, that's lasting for more than 24 hours, I think it's worth discussing that with your neurologist or primary care physician and making a decision based on that.
I wanted to know if MS affects the mouth, like the teeth, or is that possibly due to vitamin deficiencies that are causing teeth to break, decay, and things like that? That is like, it's something that's happening rapidly, and since someone has MS, everyone likes to blame everything on the MS. So I wanted to know if you've heard or if you know of anything with MS affecting the teeth, the oral in the mouth, and things like that.
So the short answer is no, it's not MS. And so you need to work with a good dentist or oral surgeon and take a good look at the causes of your symptoms.
The next question, can Ampera cause a UTI or abnormal kidney functions, for instance, like GFR?
So Ampera doesn't cause that. So we looked at the very first trials with Ampera. Persons who went in those clinical trials were not screened for urinary tract infections before entering the trials. And yes, in the very first trials, there were urinary tract infections reported higher on persons who were on Ampera than were on placebo. Since we did another clinical trial looking at Ampera with a lower dose, and the lower dose clinical trial, persons were screened for urinary tract infections prior to going into that trial. Although the trial did not bring forth a new drug, we did find out in that clinical trial that, in fact, persons who were on Ampera were not having urinary tract infections related to the Ampera. It was a pre-existing condition, and once the urinary tract was infection was cleared, there wasn't a higher incidence. Urinary tract infections are common in MS. About the GFR, Ampera is excreted through person's kidneys. And so if your GFR, which is your glomerular filtration rate, is the rate at which your kidneys get rid of waste products. So if your kidneys, if you're having moderate to severe kidney failure, your GFR is less than 60, then you would retain more Ampera in your system, and therefore the side effects that could occur from Ampera would occur potentially, be more severe for you, and therefore it might not be a drug that would be beneficial because the side effect profile would be so much higher. It's not that Ampera in any way harms the kidneys, it's just excreted through the kidneys.
Do indwelling sacral stimulators work for neurogenic bladder?
Closer.
Do indwelling sacral stimulators work for neurogenic bladder?
I think you said indwelling.
Indwelling sacral stimulators work for neurogenic bladder.
Indwelling sacral stimulators work for neurogenic bladder. I know of patients that have those, and so if a urologist is recommending that, then yes, there are bladder stimulators that have been very effective for persons who have difficulty emptying their urine. The FDA just approved a new device called an inflow catheter also that, it's just approved. It has not gotten out in clinical practice yet, but also helps with persons who are having bladder retention problems. So again, those are more than just little bladder problems and should be managed by a urologist. The only thing I would say about a bladder stimulator is that decision should not be made lightly, because once persons have bladder stimulators placed, they may be subject to not being able to have MRIs, or they have to make sure that they get a stimulator that is, quote, MRI compatible. So that's a decision that should be made in conjunction with neurology and urology.
Okay, my question is, will counseling be an effective way to stop taking antidepressants after 10 years? even before you were diagnosed with MS?
And can you just repeat that question again?
Will counseling be an effective way to stop taking antidepressants after 10 years?
I see. So will counseling be an effective way to stop taking antidepressants? The course of antidepressant treatment for depression in any condition varies by individual. Some individuals start an antidepressant for 6 months, get relief, and want to wean off and are okay. Others go on for a longer period of time. As Dr. Issa mentioned, antidepressants are used not only for depression, but sometimes for other issues, pain and sensation issues. So it depends. But I will tell you, the literature says that the best course of treatment for depression alone, seems to be a combination between antidepressant treatment and psychotherapy, in particular cognitive behavioral therapy. So cognitive behavioral therapy tends to work pretty well alone. Antidepressants, depending on the situation, can also work pretty well alone. And the combination of the two seem to work the best overall together. But to get specifically at your question, it's very possible that yes, you can certainly come off an antidepressant and benefit from psychotherapy or counseling to the point to where you feel as good or better than you did while you were on the antidepressant, for sure.
Next question is about Tecfidera. They want to know about the drug efficacy and how long it takes before the drug starts to kick in, and if while you're flushing, your core body temperature goes up.
Okay, so Tecfidera is an efficacious medication. It was proven to be reduce relapses, MRI activity, and disability. And it starts working, as early as within the first month. And so monitoring persons appropriately whenever you change therapy. As far as the flushing, for some persons, they do describe that with that flushing, they do feel that their body temperature goes up. It's going to be not typically something that you would be able to measure on a thermometer. The core temperature may go up just a little bit, but not something that you're going to be able to take your temperature and you'll be 90, 96, and then you're flushed and you're going to be 99. Typically, it's not that dramatic a reaction, but persons do describe feeling sometimes a warmth sensation, and that flushing can be just a warmth sensation. It can be a redness to the skin. It can be a rash to the skin, and typically that fluctuates throughout the day, and not continuously, and again, is a transient type of symptom that usually resolves within the first 3 months.
Yeah, I always speak with people, and people ask, how long have you been diagnosed? Or is there a way or a test that will tell you exactly how long you've had MS?
So I think the short answer would be no, because you can have symptoms and changes in your brain MRI scan even before you've ever had any symptoms. And nowadays, where there's so many MRI scans being done on people's brains because of other complaints, you do have what they call radiologically isolated syndromes. You can find MS changes on a brain MRI for someone who's just coming to see a doctor for a migraine or some other nonspecific complaint. So I don't know that there's a good answer for that. I mean, symptomatically, you could maybe go back to an event that you think was the first dramatic event that made you think you had some abnormality in your nervous system. And then from the time of your diagnosis is when it's firmest. But I don't know if there's any way to really go back retrospectively in your life.
If both parents have an immune system disorder, how could this affect their children? That's the question.
So if both parents have an autoimmune disorder, well, I think that just in a very general sense, their children would be at some slight increased risk of developing an autoimmune disorder, but it's not like a one-to-one transmission where, if you have a problem, your mother had a problem, you're absolutely going to have a problem. So and I don't think the risk would be, even approaching close to anything, like approaching like a 50% or some rate that most people get worried about.
Before, I don't know if this question was asked before, but somebody just asked in Spanish. So, ¿cuánto tiempo debe estar desempleado antes de got una solicitud. How long do I have to be out of work before I apply for disability?
You can apply for disability at any time that you stopped working. You just can't be working. The impairment has to be 12 months or more. So sometimes Social Security office will say you need to be out of work for 1 year before you can apply. But that's not true. You have to be out of work and expected to be unable to work for a period of 12 months or more. So my suggestion, especially in the delays in the system, is to apply as soon as you've been diagnosed or as soon as you feel that you're not capable of working. If you are able to return back to work, then your application gets dropped. If you continue to be disabled and unable to work, then you can follow the system. The case takes between 18 to 24 months to resolve at the Social Security level. La pregunta es cuánto tiempo uno debe de estar incapacitado antes de erradicar una solicitud, y la sugerencia mía es que apliques apenas sepas que no puedes trabajar consistentemente. Apenas uno sabe que no puede trabajar, puede erradicar. La Oficina de Seguro Social, la Oficina del Distrito, normalmente dice tienes que estar desempleado 12 meses, pero tienes que estar desempleado 12 meses es la definición. O sea que si tienes una condición que te previene trabajar por un anticipado de 12 meses o más, mi recomendación es que apliques, radiques una solicitud de inmediato y dejes que esa aplicación proceda. Normalmente toma de 18 meses a 14 meses, 24 meses para recibir una decisión favorable.
Thank you.
Okay, next question is about physical therapy and the best way to gain longer steps in stride.
Well, so I think that probably the main thing would be to just working with the physical therapist to try to analyze your gait and try to understand what things are limiting your ability to generate a stride. So maybe some spasticity issues and maybe some hip flexure weakness issues. So trying to identify what variables are affecting the way you're generating a stride would then allow you to focus with the therapist to how to counteract that. And if it's something like significant spasticity, sometimes medications or Botox in combinations with therapies can be helpful for that.
Hi. I went to a symposium, and there was a Dr. Hickman talking about rejuvenating myelin in trays on mice, and he was being very successful. Saying that, I asked him the question, okay, that's fine that you're rejuvenating this myelin, but it's called multiple sclerosis, and sclerosis is a word scarring. I said, now, how are you getting rid of the scarring? It's fine that you're rejuvenating the myelin, but that scar is still there. How are you getting rid of the scarring? He's like, in the trays, in times, we're going to learn. But my question is today, we're talking about therapies and everything like that of how to live today with MS. But what are we doing for the future of finding a cure?
Well, I think that, you know, the work that physician is doing in trays is part of what is leading us closer to a cure. You know, we have had a proliferation of disease-modifying therapies. We're still going to have more disease-modifying therapies. As Dr. Issa pointed out, we have research trials looking at secondary progressive. We're looking at research trials in primary progressive. Every research trial in developing a drug leads us closer to why is that drug effective and what is going on, what's the pathology, the holy grail of what we don't understand about the disease, you know. And so it's such a multifaceted disease and is so different in every individual. That's part of the complexity. So I think that we are getting closer. I don't know of a cure that is out there that we aren't giving to individuals, but I think as we learn more and more about what interacts with our immune system, how to turn it off, how to increase it, how to repair, that leads us further to potentially a cure. We've identified more and more genes that are associated with multiple sclerosis. And so everything we learn helps us look at what the future is. We didn't know a quarter of what we know now when beta-seron first came out. So there is hope in the future. I just don't have the answer for a cure at this moment, but I think that, I hope in our lifetimes there will be.
Good answers. We have about 20 minutes remaining. Next question, should patients with MS have a social worker? Does one receiving disability automatically get a social worker, and how does one access these kinds of resources?
Well, I think that's a great question. There's a lot of need for social support, access to community resources when you have MS. Right, from a practical standpoint, it's very difficult to access a social worker in a clinic environment. There's no real mechanism for, at least certainly not in our clinic, for contracting one or supporting a social worker. My experience has been very limited to just social workers in the hospital setting to try to help patients. I don't think when you have disability benefits that you automatically are assigned a social worker that I'm aware of. You know,
no, I actually know that I advise clients if they've been in the hospital for any reason, you get assigned, or look for a social worker because they have access to so much information locally and in the community, but you don't automatically get assigned a social worker.
The other thing is most of the organizations within multiple sclerosis have social workers. So the MS Society has a social worker, the MS Foundation, the MS Society of America, MSAA, they all have social workers. And so if you don't have access to one through a hospital system where you've been or one in the clinic that you're going to, then you can reach out to one of those organizations that has social workers. And you know, the wait may be a little bit, but they do have social workers to work with you.
I have a question regarding if you have a child that's disabled or has an illness, do they qualify for disability or does it go to SSI?
That's a two-part question. A child goes normally through SSI. There's also a disabled adult provision for a person that's over 18 that was shown to be disabled prior to 18. Then it goes through the parents.
Question. How much of MS should I share with my peers in the workplace? I am afraid of being targeted for my illness by administration. My supervisor insists I use a cane always. I've always been asked why I don't seek permanent disability.
I'll start and then pass it along. I want to say share as much as you're comfortable, but I hesitate because it's a real concern. And maybe Lisa can follow me. There are employers that, despite ADA, are less willing to work with you, and if they're able to document and find reasons that your condition interferes with your ability to perform your job, it can create real concern for you. So from a psychological standpoint, to start at the beginning of the question, as much as you're comfortable sharing with close ones, to include coworkers, is where you really ought to start the process of thinking through. And then as it extends into, well, what are the real practical implications of me disclosing this in the workplace, then I think you need to start weighing the realities of ADA support with the realities of the fact that some workplace environments are going to be looking to find reasons possibly to replace you or document that you're unable to perform your duties. Of course, this is all in the context of if you're still willing and able to work and want to work.
Okay, so I will add to that if you are working, you do need the support. First, the main question is whether or not the employer employs more than 50 people. If there's more than 50, then you fall under the ADA category. If there's less than 50, then an employer can dismiss at will in most states. So at will means they can dismiss you whether they write it up or not, whether you have MS or not. So I think the real question is whether you feel comfortable and whether or not it interferes with the ability to work. Whether or not the ADA covers you has to do with how many employees are in that corporation or in the place of employment. And then ADA may be an issue, may not be an issue. So protect yourself before you even start talking. Know really how many employees there are before you want to start giving information out, so you have some level of protection.
I recently heard about a procedure from a support group member where MS patients have their bone marrow extracted and then put it back into their system to reverse MS. I wanted to know, how does this work, and has it been positive? Has it been any positive outcomes in any previous trials?
So there have been some studies, small, really just published data on patients who get bone marrow transplants for severe forms of multiple sclerosis. I think that's what you're referring to. That's what I'm thinking about. There might be some other bone marrow-based therapies, but those are serious interventions. When you undergo a bone marrow transplant, you have to have your immune system completely suppressed, and it carries a real risk of passing away during that procedure. So it's usually reserved for patients that have profound and severely aggressive forms of MS. But it can be beneficial when you sort of reset somebody's immune system with a bone marrow transplant.
Social media has actually come alive here because my phone is going crazy and I can't even read all the ones that are on paper. We have 15 minutes and I need to give you guys some of these questions. I was an engineering student for the past 3 years and not working. Within the last year, my inabilities have grown both cognitively and physically. Do I still qualify for disability? What about the school loans that I've accrued in the past 3 years? If I am qualified for disability, if later I'm doing better, can I go back to school?
Yes to all those questions.
Okay, next one. Can you please share information pertaining to remyelination using human growth hormone? Are there studies that show HGH, it's my eyes, HGH helping MS patients?
I'm not aware of any specific studies for human growth hormone and improving remyelination, but it doesn't mean there may not be some reports out there.
I don't know.
I don't have any experience with that.
Okay, the next one was, she's evidently gone through a lot of different testing for the MS, between MRI and spinal tap and evoked potential testing and other things. And she wants to know how the doctors actually come out with that she has one specific type of MS.
Well, all of that testing is used to determine whether a person has MS. So the evoked potentials, the MRIs, the spinal taps, the blood tests are all looking for ruling out the mimics of MS and pointing to that this is a disease of the central nervous system. The type of MS really depends on a person's history. And so when you first diagnose a person with MS, unless they come to you with a history that says they've been declining with no acute attacks and some remission getting a little bit better, they've just been declining, then you worry that that person may have a more progressive form of MS. But if they come to you with the history of either this is their first attack or they can remember a year back or in the past having something that may have been MS, then you diagnose them with MS and you think that most likely they're going to be in that 85% of individuals who start at what we call a relapsing form of MS, where their MS comes, they have acute attacks, those attacks get better, they may totally remit, and then they are quiet for a period of time and have another attack. So the course of MS really is different than the diagnosis. The course is looking at someone's history. The diagnosis, all those tests are used to diagnose, not to determine a specific course.
Anybody else on that? Okay, the next one is caregiver support. Person wants to know if you think it's necessary for a caregiver to receive neuropsychological care rather than going to a caregiver support group.
No, I don't think it's necessary at all for a caregiver to receive neuropsychological testing or follow-up treatment. Neuropsychological testing, like any evaluation, is instigated by a real concern with that individual. And as a caregiver functioning in the role simply of a caregiver, that doesn't warrant neuropsych testing or treatment. But just a plug, because we haven't talked much about caregivers yet today, I absolutely do endorse and think 100% it's important that caregivers get in to some type of support group or inform themselves and get individual support. It's caregivers often are the unrecognized folks in the MS constellation. MS is a disease that families share, not one individual. And caregivers need support in order to support you, in order to feel well themselves. So it's hugely important.
Next
I'll
one.
add to that. I'm sorry. I will add to that the caregivers that are feeling, especially if anybody's in the process of applying for disability, are feeling the squeeze of difficulties and needing to really help out and supplement ADLs, activities of daily living, please document it. Keep a journal, keep a calendar. Put down the kind of specific adjustments that are being made in the home. These are entitled to become evidence, at least in the administrative proceedings, and in federal court they will acknowledge it. So it is not, it's a very, very, very important role.
Recently at ECTRIMS, there was a presentation made by a colleague of mine, Marie Namey, called Compassion Fatigue. And we recognize through the years that caregivers have fatigue, they have burden that is tremendous based off of the fact that they are supporting someone who has this very devastating disease sometimes. And so taking care of yourself as a caregiver, if you're not caring for yourself, you're not resting properly, you're not eating properly, you're not taking care of your medical illnesses, and if you have mental health issues, if you're not taking care of those, you can't take care of the care partner that you have. So recognizing that you are an individual beyond just a person who cares for someone who has this devastating disease. You know, what I know is that this devastating disease, beyond it just being a rare disease, gets more support in the form of support groups and pharmaceutical support sometimes than some other diseases. And so oftentimes caregivers are commonly with the person who has MS, and they're just the sidekick. And so, you know, it's important to recognize and take care of yourself and be active in your own health care.
I would just want to add one last thing, because I think it's such an important topic, the issue of caregivers. And I'll be brief, but I will say that throughout the years, I've probably ended up taking care of about 2 or 3 dozens of my patients' spouses or significant others because of complaints of memory, which really just ends up being issues like depression. And we had a chance to talk, so they sort of became my patients temporarily. And I will say that one of the things that I've found is, you know, caregivers put a lot of pressure on themselves, and maybe just not putting so much pressure on themselves to, quote, be perfect, try to do everything right, try to do everything perfect. I'm not sure that there is like a perfect way to support somebody. You just do the best you can do and kind of give yourself a break. I think that's so important. For some, you know, if they put too much pressure on themselves, I think they often just run themselves into the ground.
The next question is quite interesting. My grandmother had MS. My dad had SPMS. I have relapsing remitting MS. Is it safe for me to have a child that will not have MS?
Yeah, well, that's a good question. I don't know that I have a good answer. That's a good question. I think that in a situation like that, you obviously would be concerned about the genetic loading in that family for developing autoimmune diseases that affect the central nervous system. So I think it's reasonable to assume that that child is at an increased risk above the general population. But I don't know that you can tell an individual like that the child has a 100% chance of having MS. and that decisions on having a child are going to be influenced by more than just some genetic risk. But I think it's fair to assume that a kid like that, and that family in particular, is going to have a much higher than average risk of developing MS than the general population.
Okay, another great answers, by the way, from all of you. I just love it. It's a great testing program that we're doing here. Another question is that with all the meds that are now on the market for relapse-remitting MS, what is being done for research for those with a progressive form of MS, other than the current studies that are out there, but how soon can we actually expect to see something for one of the progressive forms of MS to be on the market?
Well, I think
well, we have two. We personally have two clinical trials for progressive form of MS, and so we do trials right before they go to the last trial, the phase 3 trials, before they go to the FDA. And so I imagine through the FDA process, finishing a trial and getting through the FDA process for these two trials, potentially in the next 2 years, you could have a drug out for a progressive MS. But I know that there are other trials other than the ones that we have that are looking at progressive MS. So, I would say, definitely in the next 5 years, but as early as 1 to 2 years, there may be a disease-modifying therapy out for progressive form of MS.
We're only going to take 3 more questions, and I have one of them. That will be the last one, okay? For right now, though, let's go with this young lady.
Okay, my question is, I'm on Facebook and all the media always talks about MS hugs, and I have no idea what they're talking about. What is an MS hug? Hug? Yeah, a hug.
The hug.
Oh, a hug. Oh, the MS hug. So the MS hug is a symptom that is typically from a spinal cord lesion where you feel like you are being squeezed. And so it can either be like, the analogy of a female wearing a girdle that is way too tight, or a man wearing a belt that they're trying to tighten. It truly is a sense that your body is being squeezed, or that you have a wraparound sensation. It may not be a squeezing, but it could just be a burning pain that hugs your whole torso. And depending upon the level of your spinal cord lesion is where the level in your torso that hug would be.
Okay, we have one more back there.
Yes. My question is for Lisa. Lisa, if you're disabled, okay, and you recently had a death in the family, I want to know how much money will I be able to have in my bank account without them taking it?
Oh, so if a person's disabled and they have a death in the family of a spouse, if it's a Title II case where you worked and you put money into the system, it does not affect your monthly benefits. If you are SSI only, which is a recipient getting benefits because you didn't put enough money into the system, then your monies for the month would be raised to the level of poverty, and that's defined on a state-by-state, year-to-year guideline.
Okay. Thank you.
Okay, so the last and final question of the day is, did you all think that this program was worth it? Yes. And we hope to be able to do this again. And firstly, I want to thank our viewing audience. Secondly, I want to thank all of you, but I could say that first and you guys second. But in any case, I want to thank our panelists. This was great. I love the answers. I think that everybody did. I can't wait to just promote this all over social media for people to even watch the ending of this and be able to see it again on our YouTube channel. By the way, for anybody that wants to watch, you could see this again and again. You could share it with family and friends. Those that have support groups, please urge those members of your groups to watch this as well. And again, saying goodbye to everybody in Candyland or wherever you are out there. Thank you for viewing us today.